So these are my, let's see, where I live and work. And let's see, do I just hit anything to get to the next? Okay, by disclosure, I provide scientific and regulatory consulting on medications development. That's mainly what I do. That includes abuse potential assessments, eight-factor analyses, drug scheduling nationally, internationally. We work in psychedelics, cannabinoids, and so forth. Um, my opinions are my own. I also provide advising on science and regulatory policy to the American Kratom Association. Um, I've been researching addictive substances for a half a century plus. The first drug that I worked on at NIDA in 1980 was buprenorphine, and I'm really proud of buprenorphine and naltrexone, which we also contributed to, and most of the other treatments for addiction. But they don't, for a lot of people, they don't reach them, they're not acceptable, they're not effective, or maybe they are at one stage and then not a later stage. So that's part of the reason that I support access. I don't promote anybody using Kratom per se. I support access that is ideally regulated and more research. It's an honor and a pleasure to follow Dr. Volkol. She's a hero to many of us in addiction research and policy, um, and a real pioneer before she got to NIDA. Um, but when people ask me about NIDA's, about Kratom science, I say, go to NIDA's website. That's a starting point. And so you'll see more than a little bit of overlap between what I'll be saying and Dr. Volkol, and I'll try to minimize that. But there's a lot that we don't know, as Dr. Volkol mentioned. And some people say, well, if we don't know much, how can we regulate? Well, regulation always starts before you know everything, and drugs are approved before you know everything. We do know a lot, but again, it sounds contradictory. There's a lot we do know, but a lot we don't know. More than 450 published articles in just the last 5 years. It's hard to keep up with it. A lot of it's thanks to NIDA's efforts. But there's also research around the world in Southeast Asia where they've been studying it for decades. And there's also now more research by some of you who are working on new dietarian treatment, new dietary notifications to the FDA, pharmaceutical development based on kratom-derived substances, and that's also increasing the research pipeline. Dr. Hustis will mention some of that. A good starting point, again, is the NIDA Drug Facts website. And Dr. Volkol already covered a lot of this. And I think the wording on the NIDA website is very careful, considered, conservative, if you will. But I think that's a starting point for the science. Something that was interesting to me when I first started looking at kratom more than 10 years ago was I thought, okay, why aren't people injecting it? I mean, it's easy to extract 7-hydroxymetrogenine. With most drugs that are widely abused, a lot of people like to heighten the euphoria. And very quickly, we're learning that's not mainly why people use kratom. I mean, at Johns Hopkins, we also did injection studies with nicotine and caffeine and thought, oh my goodness, you can do this, it's easy. But that's not how people want those substances. Um, Everything in safety and abuse potential, for that matter, is a relative comparative process. So oftentimes people talk in absolutes. Well, there was a kratom death, and one death is too many, or whatever. And it is. We want to minimize any risks. But in drug development, it's always also relevant compared to what else is out there. So these are just looking at FDA's safety adverse events warning surveillance system, just comparing caffeine and metrogenine to one opioid, oxycodone. The orange bars are oxycodone in different years. And the little tiny flat bars, which you can hardly even see, are caffeine and metrogenine. It's a relative process, and that's important to keep in mind when you're thinking about public health and harm reduction. And Dr. Volkov touched on that as well. Again, as you'll hear kratom referred to as an opioid. And 10 years ago, a lot of Kratom researchers were saying, well, it's an atypical natural opioid. Well, it's not an opioid by nature, law, or chemical structure, but it does have some opioid effects that are important. If it was actually an opioid, we wouldn't be here because it would be listed in the Controlled Substances Act. Respiratory effects, Dr. Volko mentioned this as well, and Dr. Husis and I and a few others did a study based on the FDA recommended protocol, which compares the target substance or combinations with oxycodone. And so our goal was to push the mitragynine dose as high as was physically possible or until death. And we got up to 400 milligrams per kilogram, and that was as high as we could actually get into the animals. And basically on the green side, that's oxycodone. The top bar, that's the therapeutic dose equivalent in a rat. No respiratory depression. It's pretty safe for all practical purposes. But at the higher doses, Death Valley plummeting respiratory blood oxygen levels and deaths in both of those groups. In the mitragynine dose group, there is no dose effect. This was amazing. No, it's flat. It jumps around a little bit, but we did not see respiratory depression and no deaths or life-threatening effects. At the highest dose, some grogginess in the animals, which lasted a couple of hours. 10 earlier studies, and our study was not novel, we just followed the FDA model and pushed the dose higher than most people did. But this has been looked at in multiple species and other studies. Dr. Volko touched on the abuse potential, and these are rats pressing levers to self-inject morphine, which they do, mitragynine, which they don't. And if the animals were pressing the lever for morphine or in another study, heroin, and you gave them mitragynine, just like people in the real world report, it reduced the rewarding effects and they didn't take it. It blocked it. But 7-hydroxy at astronomical doses compared to what humans take can serve as a reward. And this is part of the reason we need regulation like FDA regulation to say, what is the maximum allowable level of 7-hydroxy? We need standards. 11 states are starting to do that. There's a myth that, well, if Kratom can relieve opioid withdrawal, it must be an opioid. But again, Dr. Volko touched on this too. Clonidine has been used for decades to relieve withdrawal, opioid withdrawal. It's an alpha adrenergic acting drug used for high blood pressure. And lofexidine was actually approved in 2018 for that same purpose. It's not magic. How can this be that Kratom can have some opioid effects and not affect respiratory function and not have some of the other effects? Well, it's like trains being on different tracks that go through a station. And this is a NIDA supported study, and this is on NIDA's website, or was. And basically, the pathway, if you will, for mitragynine does not recruit beta-arrestin like opioids do. And so it bypasses that way station that causes the plummeting respiratory depression. So it's not magic, it's just pharmacology. International Commission on Drugs considered Kratom for potential international scheduling, and they rejected it. And it was largely based on NIDA and other supported study. Also, they considered what they consider the therapeutic effects, and that's that in the US, therapeutic effects are defined by FDA since the 80s as FDA approval of the drug. Internationally, it's more loose. Are people actually using it in the real world, like for traditional medicine? So they rejected scheduling. Last issue I'm going to touch on, and Dr. Volko also touched on this. Some people say, well, extracts are bad, or extracts aren't bad. That's like saying I'm drinking coffee. That's an extract. But maybe something that was 10 times stronger shouldn't be. Soft drinks there's some oversight. The question is, what is the level? And I think this is part of where I would love to see FDA actively involved, because FDA is the best organization in the world to set standards for how much and how do you test it. So 11 states are starting it, but FDA could bring a lot to the table in a considered rulemaking type of process, including what should the warning label be? What should the wording of warnings be? When we address this with nicotine gum, we didn't say don't use during pregnancy for women that were smoking because they would go back to smoking. The labeling said talk to your health professional. Again, that's a nuance. I'm not saying that's what should be for kratom. The point is, FDA tries to get the warnings science-based and not overwarn and scare people who could benefit from the drug. Warnings are not simple. You don't just put everything that might happen on a label and scare people unnecessarily. So, and in the context of the opioid and other drug epidemic, important thing to keep in mind, the drug epidemic is not just opioids, it's stimulants. Stimulant deaths are increasing. Kratom, the surveys in the US and Southeast Asia are showing, is being used by a lot of people to get off alcohol and stimulants. So we have something that looks like a more broad harm reduction tool than just opioids. And finally, I testified at one FDA NIDA hearing that was premised on we need more treatments to help those that are not helped by buprenorphine. And several speakers commented on kratom. And I said that for people who find kratom to be a lifeline away from an addictive drug, we shouldn't take it away. That would be like taking away a life preserver from somebody that's struggling in the ocean because it's not Coast Guard approved. You just don't do that, but you try to set standards. So in conclusions, you've already heard most of this from Dr. Volkal, but let me finish with the last one. Although many states are beginning to regulate kratom or consider kratom regulation, we really need FDA regulation at the national level because they can set national standards. They know how to do labeling. They know how to get the warnings right. And they know how to set standards. What should the level of 7-hydroxy be? At this point, we're saying less than 1 or 2%. Well, maybe it's 0.5, maybe it's 0.8. What is the right test? We need FDA. Thank you.